Good morning, everyone, and welcome to the very first Public Safety Solutions for Substance Use Disorder Echo for the new year. I hope you guys had a wonderful start to the new year as well. This is brought to you by the Center for Substance Use Training and Telementoring, CSTAT at Beeville, Texas. My name is Shreya Prasanna, and I will be facilitating our discussion today. A few quick housekeeping notes before we begin. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. If you're having trouble accessing captions, please chat Echo IT. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, please click on the speech bubble icon on the navigation bar at the bottom of your window. Please note that we are recording these sessions for later distribution through the Beeville, Texas YouTube channel. Any information you put in the chat will not be shared on those recordings. We encourage everyone to join by video for the discussion portion in the latter half of the session. That said, regardless of how you've shown up here today, we are just happy you're here to learn alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. Or if you're on the phone, just press *6 to unmute. You can also use the reactions menu in the bottom right of your Zoom screen to raise your hand and indicate you have a comment or question to share. You can also use the chat to share your perspectives and opinions. There are a lot of us in this space, so please keep your comments brief to allow others the chance to share as well. And finally, please note that no protected health information is allowed in either the chat or our discussions, and that includes names, addresses, emails, pictures, or any information that can easily identify an individual. Towards the end of the session, the Beeville, Texas team will send out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities, and it also allows you to access free continuing education. We are approved for CEs for paramedics and any public safety professionals with a behavioral health degree. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Today's session will start with the presentation on effective collaborations between behavioral health and public safety workforces, and this will be presented by Jeremiah Goulka. Following that, we will hear a case from the community. There are a lot of professions represented here today, a lot of experiences and perspectives. I encourage you all to share that during a discussion so that we can all learn from each other in the space. And with that, we will do some introductions. Jeremiah.
Hi, everybody. I'm Jeremiah Goulka, Executive Director of the SHIELD Training Initiative, and I'm going to do the didactic today. So I'll talk to you shortly.
Thank you so much. Cynthia.
Good morning, everyone. Excited to be here. My name is Cynthia Mendiola. I'm a retired federal probation officer and a trainer in core correctional interventions, and I'm happy to be here to learn some more.
Thank you so much, Cynthia. Cody Happ.
Hi there, my name is Cody Ham. I'm a paramedic with Round Rock Fire Department's Crisis Response Unit. Happy to be here.
Thank you so much, Cody, for joining us. Andrea Hebler.
Hello, everyone. My name is Andrea, and I work here at the Center for Substance Use Training and Telementoring at the Be Well Institute. And welcome, everyone, and Happy New Year.
Thank you so much. And with that, we will move on to our didactics. Jeremiah, you can take it away whenever you're ready.
All right, I'm going to share my screen. All right, looks like we're working. Excellent. Great. All right, everybody. Hi, thanks for joining today. So the title that went out on the announcement was kind of pretty broad, like how are we going to do effective cross-sector collaboration? And so I'm just going to set some expectations now. what I'm going to talk about is a little piece. I'm not going to talk about the whole like magic of how we can somehow all work together really effectively. But instead, I mostly want to talk about not even have a notion of a full huge collaboration, but really just looking at how when the behavioral health and the public safety workforce is interface, and I'm just going to use that word interface more than collaboration because it acknowledges the fact that we're not always in a proper, real collaboration, but we do interact. How can we reduce some of the friction in those interactions? Kind of in a small picture and big picture. So, and we're going to look at related to some work that my organization is doing to try to figure out how to help with that some. So I've got no commercial interests here to disclose. Our learning objectives here, we're going to distinguish between some types of cross-sector collaborations. And we're going to talk about identifying champions and other agencies. And then at the sort of through this process, I love more ability to advocate for evidence-based trainings, which may also reduce stigma. Okay. A few acronyms for you here, because obviously we live in a world of acronyms. But LE is law enforcement, CJ is criminal justice, using that as a general term to include prosecution, public defense, corrections, jail, prison, community corrections, probation, parole. FR for first responder, so that's going to grab more of our EMS and fire. BHW is we're using as a general word to describe folks who work across the whole spectrum of substance use and mental health services, from therapists to treatment providers, harm reductionists, peer coaches, recovery navigators, etc. And then the familiar PWUD, people use drugs. All right, so when we talk about cross-sector collaborations, it's worth just pointing out that there's a spectrum here, and it's one end there's kind of none, but one way we think about the degree of collaboration is kind of about how much where is the money flowing from, and how much money is there. And so we've got your less formal is our kind of ad hoc collaborations to the next level being funded, meaning, say, Department of Public Health is providing funding to, say, harm reduction agencies to do overdose, post-overdose outreach, or co-response between, say, a harm reduction agency and a police department or something. And then there's straight up in-house collaborations, which a number of police departments will have. They've got their people in-house, whether they're social workers, whether they're doing in-house, maybe like the places where someone could come to a department and then that they actually show up at the station house and get a warm handoff that way. I know I saw got someone from the Task Center for Health and Justice, where I know you all do, and helping departments set up deflection centers. So that's something I kind of view as this kind of in-house degree of collaboration where it's very, very organized. Okay. So I'm just this is not to go into super great detail here, but just to point out that it can be formal to informal. And again, I'm talking about kind of interfacing, and what we'll be talking about some more here. It can apply to any of these. A lot of the work that actually our training organization works on tends to be more in the ad hoc area, but it goes across. So there are barriers to greater interfacing, or an interface. Again, I'm using this word versus collaboration because it's collaboration and partnership implies a degree of working together that is not always present, right? As I'm sure many of you are well aware. And so what are some of the things that get in the way of interfacing at all, or good interfacing? And again, I'm kind of thinking about this notion of friction. What's creating friction? So there's the obvious ones: lack of funding and time. There's the old one of past failures, right? Where, say, an EMS department or a police department had some kind of official or unofficial collaboration going where they were supposed to call some community-based organization, and their calls weren't going through, or no one was showing up on time, just where things kind of broke down. And for whatever reason they broke down, then it's led to a more complete breakdown over time, and people aren't calling anymore. Then there's some of it is cultural, right? And kind of lack of knowledge. Some of it's on often the criminal justice side, police and EMS side. Sometimes we have a lack of understanding of how or why different drug treatment programs work, or how they work, or how the supports work, or why they're useful. And lacking that knowledge can get in the way of wanting to interface usefully. There's cultural or past history antipathy among sectors. I mean, we know that a lot of folks in the law enforcement world think that, say, harm reduction is, quote, enabling, right? Because if you're providing safe syringes, sterile syringes, that's seen as, not mandating treatment and abstinence, and and so that attitude can lead to not seeing the harm reduction agencies as the allies for public safety that they are. We've got many people in the behavioral health world have had prior trauma from their experiences. If they, for example, were arrested, or if they've been justice involved, or they see how their clients are having trouble with their interactions. And then a number of a common problem faced across the country is where behavioral health support organizations, so say drug treatment centers, methadone clinics, harm reduction agencies get targeted by law enforcement as kind of convenient places to do warrant enforcement, and that drives people away. The people who would use those resources don't use them as much, and even when agencies are, especially with harm reduction, often kind of in a frequent sort of battle for survival because of the politics that surrounds them, and oftentimes it's law enforcement leaders will oppose their opening or their continuing existence. Not all. Some get have strong support among law enforcement leaders who recognize their value. So, but these are things that are maybe friction issues. But when you also, it's important see this in the context of the burnout and stress, burnout and turnover that's happening throughout these sectors. And if we want to keep folks being able to do their jobs, we need to be able to reduce some of this friction because of how it contributes to the burnout. So, all right. Get this next slide to move here. So there are a couple of things that that folks can do, and I'm sure this is not going to be exactly rocket science, to help reduce friction in these moments of interface. And so I'm just going to point out two. One being identifying champions in a law enforcement or first responder or criminal justice agencies who kind of get it, right? Who understand how substance use and substance use disorder and recovery, how they actually work, how to what practices can be the most effective and most public safety oriented, and successful and effective in this, and as part of that, understanding the value of the community-based supports. So that's a piece, and then there's a training piece, and bringing in high quality evidence-based addiction and recovery science training, and understanding the effectiveness of referrals, why they work, why these community-based supports are allies in public safety and public health. Okay, right. So here's where I'm going to talk a little bit about what our work is that's related to this, but then also actually pivot to asking you all questions. So, so what we do, the SHIELD Training Initiative, is very much focused on the champions and on this training, and trying to help folks who are within these different practice areas of criminal justice, law enforcement, first response, help reduce their occupational safety and health risk, reduce their burnout through knowledge and practices that also improve the health of people who use drugs, with these kind of win-win approaches that reduce crime, reduce addiction in the community. So we talk about things like referrals and fentanyl exposure, et cetera, so that in these places where they have high friction and law enforcement might be a barrier to pathways out of chaotic use, instead they're becoming more of a facilitator. All right, so we try to do that by meeting all the systems where they're at, and teach the public safety practices, provide useful local information depending on how localized we're doing the training. With this result of improving the interface, hopefully, between people in law enforcement, for first responders, criminal justice folks, so they can understand these community-based supports and have better interfacing with the behavioral health community. Okay, so where we're going with this is that it's actually been pretty successful. We've evaluated it a lot. We've seen positive changes in knowledge and attitudes and practices among law enforcement, downstream reduced risk of needle stick injury, syringe confiscation, reduced arrests, increased referrals, decreases in overdose, improved practices, and generally improving the lives of people who use drugs. So good stuff. But we're a small shop, and trying to get this to be a kind of sustainable program and to get up to scale has been an issue. And so what we're doing right now, and where I'm going to start asking some questions, is we're trying to move from a situation where it's entirely reliant on our small team doing organizing all of the trainings, to one where the behavioral health community can have the power, ideally, interest and willingness to open the doors to in their local communities, to local law enforcement or EMS or first responder criminal justice agencies, to try to bring it there. So this is what we're talking about in a sec here. And so these are some of the partners we have. SHIELD is based at Northeastern, and we're working on this project, on this NIH NIDA funded effort to do this. And Professor Brandon Del Pozo, who's on this ECHO panel hub but couldn't be here today, is one of the folks on it. He's from Ed Brown. Okay, so we're hoping to empower behavioral health workers to improve this interface with the system actors. But here's the kind of the rub, is that it's a lot of work. You all are, who are among behavioral health folks, among you all who are here, obviously, are super busy and have so much already on your plate. So how could we help you kind of want to be interested in training local agencies, identifying the champions within an agency, working with a champion to customize the curriculum to your local specifics, actually then train the law enforcement trainer, and then co-deliver a training. It's a big ask. So let's pivot over and ask a couple questions. I'm going to stop this share, and I'm going to do a different share to some questions. And I thank you for kind of going along with this kind of funny approach to this didactic that I'm doing today. Let's see, are we having success? All right, looks like we're here. Great. Okay. So if you would be so kind to use your phone or computer to join this Poll Everywhere poll. What we have here is you can either use this QR code in the corner, or you can go to pollev.com to use the internet on it, or you can do it with your phone. If your phone, what you do is you just text this number 22333. That's the number you're texting to, and the word in your text is SHIELD. If you do that, you'll be able to answer these questions, and then we can do a little polling and then talking here. So if y'all are game for this, which I hope at least some of you are, I see people are starting to answer questions. It'd be great. So what you do when you hop on, answer these, you can do as many of these as you want. Doesn't have to be just one. Of course, if no, it's only no. And just put a space between the letters to whichever one applies. And let's see how people are answering. Just gonna give it a minute and see how we're how it's shaking out. If you have champions in different agencies, you can answer as many as are accurate. Well, that's good to see. We've got a lot of agencies out here in our crowd here today. Do have some champions. A lot, it looks like the winners here are among EMS and Cynthia, because you'd be glad to see that they're numerous in the probation and parole. So we have 7 folks have none, but otherwise we have many who do have some. So we should I'm going to move on the next question, but if we have time, we'll come on back to trying to provide some info on suggestions on how to find some champions. Here's our next question. Would you or someone in your agency, among your behavioral health workers here on this call, be willing to actually train someone in these fields? I know that's not always something someone wants to, but maybe you have a colleague who's willing to. Ooh, getting yeses, good. I mean, we could be self-selecting because we're all together here on this particular echo, but we like to, it's excellent to see folks are, either they are or their colleagues would be willing to do training. This feels very resounding yeses in the sense of being willing to go to many different types of agencies here. All right, cool. So it seems like generally promising. Good. Now this is a word cloud. So here the question is, what kind of outreach to you or your for among your behavioral health workers here? Like what kinds of outreach does your agency do to different agencies? This will probably be a little bit of a messy word cloud. I think it can be, if you've got a multiple word answer, I think it's probably best to throw in a hyphen between them if possible. That's okay. If it not, but just throwing in some of what you all do. That's it's become interesting to have a sense of how you all are doing some outreach. Glad to see training's a big one already. So all folks are already doing training, participating in coalitions, attending events and meetings. Okay, good. I hadn't used Pull Everywhere in a while, but I thought it'd be fun to give it a whirl. Ah, yeah, Echo. I think we can all say we're doing that. All right, so going to events, attending events, going to trainings, offering resource, participating in coalitions, in collaboration. Great. All right. This is good. I'm going to move on to the next one just for interest of time. So here's a question for this concept of what we're talking about, shield of how to empowering behavioral health workers to take the curriculum to the local agencies. What would make what do you need? What would make it appealing to you or your agency to do it while you're on the clock? So it's not it'd be like a lot of trainings where folks could just you become certified, you do the training, but you're not like paid to do it. What do you need kind of from us? What do you need? What kind of support do you need from your organization? Continuing education credits. Yep, that's something we can help with. What is CHW? Whoever put that in, I don't know what that means. Good curriculum. Yeah, definitely. I hope that people would like the curriculum. Measured outcomes. Yeah, that's important. Information sharing. I'm guessing that's what that's trying to say. Ah, community health worker. Okay, all right. Now, I recognize I'm asking a bunch of sort of big questions that are in a context of just having a couple minutes to go into it. So this is a little bit of a superficial conversation, but I still appreciate these kind of the thoughts. All right, great. All right, well, this is helpful. Let's go to our last question here. So this is going back to the champions question from earlier. So we saw that 7 or 8 folks responded saying that they did not have champions in local organizations. So here's an opportunity to share with those folks. How have you all secured your champions? How you found them? Okay, pre-existing personal relationships. Yeah, focus groups, interesting. Members of the community. And if anyone wants to kind of come off mute here to just offer any kind of useful thoughts to share with each other on how you've met champions, I would welcome that.
I have one way. It looks like mine isn't going through, but at least not my words. But one of the ways is just contacting somebody in the agency and asking, who are your people, that are excited about, wanting to be part of, these types of projects, and who are, like their champions in that particular agency.
I imagine that could work pretty well, particularly in a small organization. With the big ones, might be a little bit challenging, but maybe through people who are finding that they join the coalitions could be good. All right. Well, I hope that I have learned from this conversation today. I hope you all have gotten something out of it. If not, I am pretty sure that the case that we're going to do after this will be good. It's got some real meat to it. So I will say thank you for listening and indulging me in talking about setting up a big topic, and then ultimately talking about a narrow slice of it that is oriented towards the training program that we do. But if any of you are interested in learning more about our effort here or want to share more, feel free to reach out directly to my email address here, jeremiah@shieldtraining.org. And yeah, great. Thanks.
Thank you so much, Jeremiah. That was a wonderful presentation and very, very interactive. Thank you so much. I believe we have like a couple of minutes for any questions or comments if anybody would like to share that.
I have a quick one. That was so great, Jeremiah. Thank you, and always interactive as usual. My little chat in one of the polls didn't come through very well, but I wouldn't underestimate the power of breaking bread with people and having a shared meal. It's just a simple thing to do, and I know everybody's really busy, but if you can grab lunch together and just get to know each other on a little more personal level, professionally, of course, but get a small group together of some of the behavioral health folks and some of the CJ folks, and just it just sort of humanizes everyone, and we realize we have a lot in common, whether it's high caseloads and all sorts of things, or frankly, the trauma that folks experience in both of these fields. And it can just go a long way, even if you have a shared meeting and you can just bring in some pizza and take a little time after the meeting to share some food together. I think that getting to know each other personally can make a big difference and go a long way. And I still have long-term professional colleagues and friends that we sort of slowly came together that way, but sharing meals over time and getting to know each other on another level helped too. So just
So very human. Love it.
I think also, I think Jeremiah was saying sometimes it's difficult when you have large organizations, but I've found it to be really successful when you even do your cold calls, and you contact the one individual in that particular area, and then asking them who do you recommend that are your champions in the agencies. And I've been really successful to be able to collect across the Western District of Texas and just doing the cold calls. And yeah, it takes a little bit of time, but that's how you really get the sources, the people you need.
Oh, I love it. Thanks for pushing back on that and for doing that work. Excellent.
Thank you. Thank you so much, Jeremiah, again. This was a great presentation. Please keep the questions or comments coming in the chat, and I'm sure he can answer that. In the meanwhile, we'll move on to the next part of our session. Thank you, Kato, for bringing up the announcements. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and the broader learning community. There is no need to prepare a formal presentation. We will provide you a case form to fill out to assist with your case presentation. Please email us at cstat@utisca.edu. Next slide. To claim your CU credit, you must complete the post-session survey in the chat or by the email sent after the session. Complete the post-session survey and select yes on the question, are you applying for CU credit for today's session? And the certificate of completion will be sent to you 2 or 3 weeks after the session date. Next slide. The Texas 2025 is now open for registration. This will be on February 27th to 28th in El Paso. You can join us in person or virtually. Please visit texas.org to register for free. Next slide, please. We are now accepting sponsor and exhibitor applications for the 2025 Texas 100% of your support will go towards providing a free continuing education symposium for all attendees, funding travel grants for experts in the field, and underwriting other event-related costs. To learn more, please visit texas.org/sponsor Texas. Next slide. And do join us for our next Public Safety Solutions Echo on Thursday, February 13th at 11 a.m. And with that, we will move on to our case for today. Cato, if you could please bring up the case, and Cody, you can take it away when you're ready.
All righty. Can everyone hear me?
Yes.
All
Thank
right.
you.
Yeah, not a problem. Hi, my name is Cody Ham. I am a paramedic with Round Rock Fire Department's Crisis Response Unit. We're a co-response fire-based team that responds to 911 calls. Is a dual response nature. So we have a paramedic and a behavioral health specialist that is a master's level clinician responding to calls, finding diversions from ERs in jail. So I'm going to go ahead and read my case. So we had a 36-year-old female that we found on our computer-aided dispatch. 911 had been activated. She was found apneic and unresponsive. There was no Narcan available, and she was found with intravenous substance use supplies in the room. The man that found her was her coworker and was instructed to start CPR. He'd begun compressions. An EMS commander was en route. He administered 0.5 milligrams intravenous naloxone while the transport unit arrived and began breathing for her. She woke up upon our arrival. We arrived at about the exact same time as PD. So our team came in, and the patient was initially trying to refuse EMS and transport. She was very concerned about being able to work that day and was still fairly altered. Because of the severity of it, we worked with kind of motivating her to get onto the stretcher and to kind of move into the unit for transport. She eventually consented and we helped her. We got her on the stretcher and we moved her quickly into the EMS unit for transport. When that happened, during transport, we drove our own vehicle to meet them at the emergency room that she was transported to. During transport, she became increasingly altered again. Her CNS depression increased, her breathing status decreased. They were able to keep her awake and, with verbal coaching and avoid further naloxone administration and avoid any withdrawal symptoms. When we got to the ED, the receiving physician kind of met her immediately and said, "Hey, if you keep falling asleep, I'm going to Narcan you," as a threat. And she struggled to stay awake. She was vomiting. She was kind of ill. So our team remained with her, kind of kept her awake and did verbal coaching while we waited for family to arrive to continue that verbal coaching. Because we were already at this facility, we got all the information for a follow-up. We provided naloxone rescue kits to the family. And we tried to stay as long as we could. Unfortunately, our team got dispatched. We had 2 calls in holding that were also emergent calls. And because our patient had already been in a receiving facility, we had to triage that. We got her information to follow up. Later in the day, we found out that she had been discharged and was back at the hotel and resting. The plan was to follow up the following Monday after she had rested. Unfortunately, when we reached back out to her, she did not respond. We are continuing to reach out as we can, and hopefully we can remake contact and tie her back into services.
Thank you. Thank you so much, Cody, for presenting that. I'll open up the floor for any questions or comments our community might have for you.
Cody, by any chance, did you get any information that this person might be on, under the or a justice involved individual where maybe follow-up can be continued with that part of her life?
Yeah, so that's what's interesting is so part of our computer aided dispatch system is we are connected into the police department's dispatch data, so we can see if they are justice involved, and we can kind of use that as information to drive further intervention. We know that if someone has multiple charges for PI or for having a substance, that will kind of drive some of my perspective intervention. With this individual, there was not much information about being justice involved, so it was kind of limited. What I would say is on scene, the response of PD and them determining whether or not this was going to be a case they investigated was a potential barrier that we were able to kind of navigate.
Thank you. That's good to hear.
Yeah.
Yes, Kristen? Kristen, did you have a question? I don't, your audio isn't coming through. Did you want to type it out for us? Yes, Jeremiah.
Sure, thanks. So I had kind of two questions I wanted to explore with you, Cody, on this one.
Yes, sir.
So one is on the information, because I see you said that would be you would have liked to have been able to provide more information or connections to harm reduction or other. So so on that question, what kind of when if you're providing some information, but you wanted to provide more information, can you kind of talk us through like what you provide and why you didn't or why you couldn't or what was the limitation to
Yeah.
provide
Yeah,
information?
certainly. So we kind of, we kind of have like an order of operations in terms of triaging the importance of interventions, right? For us, the most important intervention is getting that naloxone out, making sure they have access to naloxone, and then kind of furthering it to other harm reduction supplies. The more information I can get from that patient in terms of what has worked for you in the past, what hasn't, have you ever had MAT, are you enrolled in any services? The more I know, the more I can maybe reconnect, the more I can refer to appropriate services. If I have someone that is interested in a full detox and rehabilitation program, then I can drive that a little bit more. I can kind of try to keep them contained. And with OSAR, right, I can contact my crisis OSAR counselor and have them reach out. Hey, this person just overdosed. They have intravenous drug use. They're high risk for overdose. We can kind of prioritize that in getting them into services. Now, let's say that this patient, is not interested in that and saying, hey, I want to keep doing what I'm doing. Okay, well, let me get you access to harm reduction services then. Let me get you some peer recovery, some peer services so you can start relating. And we kind of slowly start opening that door. So if there is a time where they do decide that, hey, I want to get on MAT, sweet, let's do it. Like we're all ready to go. There are some patients that I've seen on and off for over a year and a half that are like finally gotten enrolled in MAT and then kind of pulled away from that after several overdoses. So this is kind of like with this patient, yeah, this might not be the first time or like the last time I see them. And hopefully every time I see them, I can build that rapport and give them more services. But it depends on how much I can get out of them and how much they can share. Because she was pretty ill, she was not in a state to share as much at that time. And I would love to get a hold of her to give her more. So we started with the naloxone rescue kits, basic history, and then I texted her my information, my card. I have a direct line that they can reach, and also giving them the basic line for our dispatch.
I
Right.
like that you meet these individuals in the place where they're at, and that's what it sounds like what you're talking about. Are they ready for MAT? Are they ready for this? And you meet them where they are. That's just awesome work, Cody.
Hey, thank you. Yeah, we really try to focus on patient-centered and individualized treatment and understanding that like if we force a treatment on someone, or if we force an intervention on someone that they don't want, it's just like, it goes back to our basic stuff, right? If I do an intervention as a medical professional on someone without their permission, that's battery and assault, right? So if I can kind of keep that in mind, even when I'm doing these more, social determinants of health interventions, remember that their consent is key to this, and their buy-in is key to this. That's going to be my most effective intervention.
Thank
Great.
you
I
so
have one
much,
more
Cody.
question, but I'm happy to let someone else from the group jump in first.
Jeremy, you can go ahead.
Okay.
I think. Yeah.
So then my other question, and yeah, I agree that degree of to pick up on Jennifer Mendez's things, that it's amazing that you actually offer the peer support services beyond OSR screenings and options for follow-up. And I agree, that's awesome. And it's an interesting kind of choose your own adventure. You kind of go where the doors are open. On the one thing that you mentioned, with concern in the case study was this sort of threat to Narcan the person if they don't wake up, and maybe to do a high dose Narcan. Can you kind of like talk sort of through that? Because I think it seems like that was concerning to you in the case study, and I'm sure it's concerning to most everybody on this call.
Yeah, I think one of the things that you see in the pre-hospital and in the emergency department setting is a punitive response. This kind of carried over punitive response from stigma and this misunderstanding that this person chose to overdose, correct? And so they are going to punish them, right? It's this idea that they are doing something wrong, not that they are presenting with a medical condition, right? And because of that, we're going to have the most pragmatic, what in their head is the most pragmatic answer, right? Large dose naloxone. You're going to stay awake. You're not going to fall asleep. And like you are going to you're going to not overdose, right? But what they fail to realize is the consequences of that, of the patient leaving AMA and now being 40 times more likely than a member of the lay public to die, right? By giving that dose, they did not treat the condition, right? When you look at other pathophysiologies and treatments, right, you don't give certain interventions at certain times and at certain doses because, yeah, it might stabilize them for that period, but we know that there's going to be fallout from that. And it is a response of burnout. It is a response of stigma. And and what I would say is it's not if I asked that provider, right, did you threaten this patient with Narcan? They would not say, no, I didn't threaten them. I was telling them what I was going to do next, right? But what they are failing to see is that for that patient, that is a threat. And for people that know what this is going to do, it is a threat. And what I was so happy to see was the lower, more clinical dose that was provided by the EMS commander on scene. That was still a little high. 0.5 is a little high. I do bumps of 0.1, right? When I'm in the field. And that usually, because we are treating to respiratory status, right? You want someone to metabolize that medication or metabolize the opiate that's in their system without the respiratory depression, but also without the withdrawal symptoms. And as you guys saw, she was a COW score of 29 when I got there. So she was vomiting, she was shaking, and that was just with 0.5. What I was very concerned about was a 1 milligram IV push that could really send her into such uncomfortable withdrawal. She would do anything to try to feel better and leave AMA and maybe be back at square one. And so kind of building these providers, the understanding. And so one of the things that I did, that we did, it was instead of being like, you cannot Narcan this patient and kind of getting in their face, which I've done in the past, right? Was, hey, we're going to have a family member try to keep this patient awake. If you guys have to administer naloxone, please call us back. Please let me know so I can come back out and coach my patient through this, and I can maybe start making some calls to get them on Suboxone or something like that. And I can maybe try to talk to your pharmacist. I can try to do some things like on scene to make sure my patient isn't sick if you make that decision that I disagree with. At the end of the day, I'm not the doctor. I can't force anything. I can try to change your mind, but at the end of the day, they can chart that as an appropriate intervention. And that's what gets tricky, right?
I think that is a very important topic, and it doesn't, not only doesn't it extends from a life-threatening situation, but it also extends into the field. You know, like for example, I'm talking about my field background, which is criminal justice corrections. I mean, a lot of times people in my field threaten treatment. And, you know, treatment is not a punitive action. Treatment is opportunity for that person to get better, improve their condition. And I think that is a very important situation. You know, in your case, it could be life-threatening. In our case, it could be the success of a person in their life.
Yeah. Yeah, absolutely. And I think like, as we know, like with the social determinants of health, yeah, like getting them into something that works for them, or and avoiding these negative pieces, right? And improving it, right? Because then you can avoid the comorbidities that might come with substance use, right? And that's the importance of the harm reduction piece, right? If we can introduce a source where they can get, safe syringes, and they can get test strips, and they can get everything to avoid the overdose, right? They can eventually bring some stability and avoid the comorbidities that might come with this, because it's going to be a lot harder to manage your substance use and all these other factors if you're also dealing with a congestive heart failure due to an endocarditis that you've developed from intravenous use, right? So let's try to minimize the harm and try to maximize the effect and the stability we can bring. The chronic illness model is such a great way to look at it, right? Our diabetes patients, we don't punish them for not taking their insulin. We don't punish people for eating more. There's the stigma with it, right? But we are going to treat that patient, right, as a medical patient, and it's this kind of disconnect that this is a medical patient, right, that needs to be treated with respect and with the appropriate interventions.
Well, I think regarding the conversation of champions earlier, Cody, we can see you clearly are a champion.
I appreciate it. Our team works very hard to make sure that our patients get everything that they deserve, and working in collaboration with all other first responder agencies is an important part of that.
Thank you, Cody. I see a question from Elizabeth Felix. Why would they threaten the patient?
Again, I think it is a consequence of burnout. I think it is a consequence of stigma. I think that in the minds of the providers, they are not seeing it as a punishment. What they have seen, what is happening is the culmination of these labor pressures and of the lack of systems to provide definitive care. And what we know definitive care to be for something like opioid use disorder is MAT and harm reduction services. It is not like naloxone is a quick rescue medication, right? So they're saying, I don't want to have to monitor your breathing status. I don't want to have to do this, give you oxygen. I don't have to do all these things. And the hospital itself was about to be put on diversion status, meaning that all their beds were filling up. So now you have this doctor that is trying to prevent a patient from becoming a critically ill patient. And in his head, it's like, well, I'm going to do the quick fix, right? Because I don't have the time to do all these other things. And that is a labor pressure as well as a stigma pressure, right? They see this person come in, they say, here we go again. You've seen this look on, if any of you have been in the emergency department, you've seen this look on providers' faces. And so to be able to advocate and recognize, hey, this is a labor pressure and this is stigma. How can I build this barrier, or across this barrier with this provider and get them to remember that this is a human being and the negative health consequences. And as a behavioral health worker, it might be very difficult to have a medical conversation with a doctor that is making this decision, right? That is a consequence of the hierarchy of medicine. As a paramedic, it is difficult. I have found some of the most success working with pharmacists and the nursing staff to kind of be like, hey, this is what I'm seeing, because they can ask the doc, hey, maybe can we do 0.1? Like, can we do these lower doses? And remembering that, like, hey, if you give them 0.1 and you support the breathing status with supplemental oxygen, like you can have a patient that is feeling well, and you're not going to be having to give them additional medication for the pain, nausea, and discomfort that you are causing, or have them leave AMA and have them come back much more sick. So it is a conversation of triage, of labor pressure, of stigma, and how do we balance all of these, right? And I think having good connections between grassroots harm reduction agencies, peer support groups, and healthcare providers is one of the most important places where that can happen. And our justice involved folks as well.
That's a great point. Thank you so much, Cody. And I see here a comment from Jody as well about leaving with the patient a laminated small credit card size card with resources available for options if the patient desires help, harm reduction, recovery, therapy, MAT.
Yes,
Yeah.
that is a great thing. We have our own little business cards, and we try to explain everything we do. And that is a great point, right? Having a more go-to, okay, well, if you don't want to call us, here are some other things we can do. The fix that we have for that often is that I will say, hey, this is Cody with Round Rock Fire Department's Crisis Response Unit. It was great speaking with you today. Here's my card. Let me know if you need anything at all. Here's 2 resources that I think you might benefit from. Just text them the websites. Now, I understand that not everyone's going to have a cell phone. Not everyone's going to have that ability. And I think discussing having a laminated kind of basic interventions card would be very, very useful. One of the things we do also leave is our naloxone rescue kits, which has 2 intranasal kits, 4 milligram, a rescue breather, instructions in English and Spanish, and an instructional video on a QR code. And not only do we carry those, but all of our fire apparatuses have them, and it generates a follow-up for us. And so that is another way that we can kind of get people tied into basic services or start that conversation.
Thank you so much. And this has been a wonderful discussion, but in the interest of time, we will now move on to the next part of our session. Thank you again, Cody, for bringing this wonderful case and discussing this complex case with us. Cynthia, may I now request you to please summarize today's session for us?
Yes, thank you, Cody. That was wonderful, and Jeremiah, you as well. I think a couple of key points that was emphasized is, there's a need for stretch, kind of expanding out and being able to find those champions that different agencies can come together, collaborate, and do the trainings and extend those trainings beyond. I think those are important things, and that Jeremiah was talking about. The sustainability is a key thing. It's hard to sustain that, and that reaching out to other agencies and getting those champions is a good way to get the trainings out to the community organizations. And so those are just the two takeaways that I saw in the training today. And I thank Jeremiah for that presentation. And then there were also some key issues that came out of the case staffing that Cody gave us, that the big barrier of burnout and just quick fixes and the cookie cutter kind of things to do, which it's really important. We have to remember that the lives of people and the life-threatening situations that could come because of that. And also extending into the field when you work with these individuals is that you don't use treatment for services and treatment for counseling and MAT and all of those things as a punitive situation. And I think that's very important also in my field, the criminal justice field, because I'm included there because I was a probation officer, but we tended to say, okay, well now because you messed up in your recovery, you're going to be punished with treatment, and that's just not the way to go. Thank you.
Thank you so much, Cynthia. And thank you again, Jeremiah and Cody, for speaking today. And thank you all for attending today's session and for this wonderful discussion. As a reminder, to earn continuing education credits, please complete the survey using the link in the chat. If you would like to present a case, please email the BWell team at cstat@yothiska.edu. Our next session will be on Thursday, February 13th at 11 a.m. Central. Have a wonderful rest of your day. Thank you so much. Bye-bye.